Okay, good morning, everyone. Thanks for joining us for the second installment in this series entitled Innovations in Diabetes and Cardiovascular Health. So just a few reminders that we've gone over before. Please don't disclose any private health information during your case presentations. This is about cardio. We've been around, this is the 6th year. It's kind of hard to believe, and you can read that at your leisure. Next slide. And today we have some really interesting cases, as well as a great presentation by Karen. And our discussants today will be Drs. Przezinski and Werner. And I think they're well suited to discuss the cases that we have on hand. These are our disclosure statements. So no changes, I believe, from last time. A reminder, we went over this during the first session about person-centered language recommendations with respect to identity. But in addition to that, the newer ones are socioeconomic status, and please try to avoid violent language. And with that, we're going to discuss continuous glucose monitoring. So Karen, please take it away.
The objectives today are to list indications for CGMs, identify candidates and strategies for successful CGM use, describe recent device innovations, and insurance coverage of CGMs. What is a CGM? It is a device that constantly measures glucose levels in the interstitial body fluid area. Some CGMs like Dexcom measure glucose every 5 minutes. Some measure glucose in the interstitial area every minute, like the Freestyle Libre. And parts of a CGM include a sensor, a transmitter, and a receiver. There are real-time CGMs, which is a CGM that streams data continuously to the receiver. And there are intermittently scanned CGMs, which intermittently scanned, you have to the transmitter needs to be scanned by the receiver to obtain a reading by the user. CGMs can provide alerts for highs and lows, which should be personalized by the user. How do they work? So the CGM sensor sits in the subcutaneous area in the interstitial fluid. And so there's a little filament that sits under the skin when the sensor is inserted and the transmitter is connected to that. The sensor sends the glucose signals to a receiver. And what I think is important here is to know for the user that a finger stick blood glucose doesn't measure the same thing as a sensor reading. And I think that that's important for them to understand so they trust their device when they transition to a sensor. And there are times when the sensor reading may be somewhat different from the blood glucose reading, especially when blood glucose is moving quickly up or down, such as when a person's taking insulin and the blood sugar starts to drop, the sensor reading may lag a little bit behind. The algorithm tries to make it as accurate as possible, but I think it's important for people to understand that if they've been exercising or they're on a treadmill and they're trying to see their sensor reading, sometimes it won't be even readable because their blood sugar reading is moving so quickly. So it's helpful for people to understand that because sometimes they lose trust quickly and just take it right off. And also what's really beneficial about CGMs, of course, is that you have trend arrows that indicate speed and direction, so you can kind of get a window of what's happening in the future. There are professional CGMs and personal CGMs. Professional CGMs are owned by the clinic and placed on people for a brief amount of time, usually 3 days, could be up to 14 days with a Freestyle. Insurance coverage is pretty good for professional CGMs, and they aren't compatible with other devices, and they're probably going to be blinded, not always, but can be or may be blinded. It's really just to give the professional some data to look at the visit with the user, so that they can see what's going on a 24-hour scale. Whereas personal CGMs are owned by the user, they can see the data, and they may be linked with other devices such as insulin pumps, of course, an app on your smartphone, or a reader, and Medtronic sensor, the Medtronic Connect will link with the insulin in-pen device. And here's the two professional CGMs currently on the market, Dexcom G6 Pro and Libre Pro. At the bottom there, it's interesting to understand too that there are interfering substances with some of these CGMs. Hydroxyurea interferes with accurate readings for the Dexcom, and high dose of vitamin C over 500 milligrams a day. So when you're talking to a person about maybe their choice of personal CGMs, or if you're going to use a professional CGM, you might want to check their med list or ask them if they're taking high doses of vitamin C or if they're on hydroxyurea. And I'm not going to spend a lot of time on this chart, but I think it's a really nice chart. There's a link below the chart where it's derived from. But what's really nice about this is it kind of shows you all the details about them, whether they link to which pump. For example, Dexcom links to the Omnipod and the Tandem, and where you would, if they have a receiver, or whether you just use an app. And that's important to know because Medicare will not cover, will not reimburse for a sensor unless the user has a receiver. They do not reimburse for just, using the app on a smartphone. So that helps you make a decision on the sensor to order for your person depending on their insurance. It shows you the warm-up time, and then it shows you drug interactions at the bottom there. So it's a handy little chart. It's a little more detail. The Dexcom G6 comes with a transmitter that lasts for 3 months. It has an internal battery. So the person will get a transmitter every 3 months, and it has a code on it that needs to be linked to either the app or the reader. Dexcom G6 has both, a reader, or you can just use your smartphone. So Medicare will cover this one. Then you get sensors that you wear for 10 days. So you'll get like 3 sensors a month, and then every 3 months you have to get a new transmitter. The transmitter is snapped into the sensor. And one thing that's really important to teach your user is that don't lose the transmitter. If you go in for a procedure or into the hospital, often what happens, or I've come across it a few times, is that the sensor is removed along with the transmitter and thrown in the trash. And then the person is stuck without a transmitter and having to scramble to see if the company will send another one. They are kind of pricey, or they have to wait 3 months for another one to come. The Dexcom G6 doesn't require any calibration. It can be used to make treatment decisions. Not all the sensors are advisable to use treatment decisions. Some of them recommend that you do a finger stick, like the Medtronic Guardian Connect. It's covered by Medicare B, and Ohio Medicaid also pays for it, and many private insurance companies. Dexcom G7 is coming. I'm not sure when, but it's being used in Europe. It's pending FDA approval. And what's great about this next generation of Dexcom G6 is you won't have to worry about saving that transmitter, making sure it doesn't get thrown in the garbage at the hospital, because it's going to be all in one. The transmitter and the sensor are all in one. It's a lot smaller. It's still a 10-day wear. The warm-up period is shorter. And you can also wear it on your back of the arm, because the Dexcom G6 is actually only approved on the abdomen. So a little more versatile, shorter warm-up period, and a 12-hour grace period to replace expired sensors. So nice improvements on that. And it's smaller, which is cool. The Freestyle Libre 2 comes with a reader, so it will be approved by Medicare, and the Dexcom G7 will have a reader as well. So Medicare will approve that. The Dexcom 3 is the newest generation, and you see the smaller circle on the arm on the right. That actually does not come with a reader. So if you have a Medicare patient, as I understand the rules right now, you would not want to order Freestyle Libre 3 for your Medicare patient, because it may not be covered because Medicare requires a reader to go along with that. So you would order the Freestyle Libre 2 with that one. It doesn't mean that they can't use a phone app, but Medicare won't cover it unless a reader accompanies the sensor. The Freestyle Libre 2 is a transmitter and sensor in one, and it wears for 14 days. The Freestyle Libre 2 is an intermittently scanned one, so you have to scan with your either smartphone app or your reader to get a reading. The Freestyle Libre 3 is a continuous streaming to the app, so you don't need to scan it anymore, which is really handy as well. And then the Medtronic Guardian Connect and Guardian 3. So the Guardian 3 only pairs with the pump. You can't wear it alone. You have to order the Guardian Connect CGM, and then there's no reader with it. You have to download the app on your phone. So Medicare doesn't cover the Guardian Connect CGM, but it does cover the Guardian 3 that pairs with the pump. The Guardian Connect CGM also pairs with the InPen, which now Medtronic owns. And that's a 7-day wear, and you do have to use finger sticks to validate before you treat with that. The Senseonics Eversense is an implantable CGM, a surgical incision's made in the skin. The sensor is tucked in, steri-stripped over. The person who's inserting it needs to be trained by the company. There is, of course, a cost incurred with that. And then the transmitter is worn over that on the back of the arm. And you have to be 18 years of older to get the Senseonics Eversense. Medicare, I'm absolutely not even sure. I don't think it covers it because it doesn't have a receiver. And it's a 6-month wear, and they're working on one that can be worn for a whole year. The cool thing about the Eversense is that if a person decides to go cliff diving, for example, they can take their transmitter off and not worry about losing it. The sensor won't be damaged. It's under the skin. So it's the only sensor where you can kind of remove the transmitter at will and then put it back on, which is interesting. And the nice thing also about these CGMs is that, loved ones can see the data. So if a child is on the Dexcom and, their parents are at work, they can see what's going on with the blood sugars, the sensor glucose readings while the kid's at school. And that's really nice. So I've kind of put the clinic app name, which is the professional account. So when I'm going to look up a patient to see what their sugars are looking like, I'm going to go to the clarity.com. And then when family members want to have the app to follow their loved one, they're going to use the Dexcom Follow app. I find all these different terms real confusing, so I laid it out in a chart because I just think there's an awful lot of apps out there. So what's the benefits of CGM? The picture kind of shows here the different scenarios that you might find with a patient, even though their A1C is 7. They could still have highs and lows and a lot of variability, but their average A1C is 7%. And as we know now, time in range is really important for us to try to help people achieve. 70% time in range is what they're advising that we shoot for. And you can see what's going on, you can see patterns, and then really collaborate with the user, to think about next steps and strategies to improve blood glucose overall. Also, the user gets direct feedback all day long, and so they're already learning and making changes on their own. If you do finger sticks, you might get, on average, with an insulin user, 4 sticks a day. But with these CGMs, you get, from 200 and something to 1440, depending on the sensor you're using. So lots and lots of data. And it does, consolidate that data so you can kind of see it and make sense of it, which is really great. Who should be considered for a CGM? Well, anyone that's taking multiple daily injections of insulin or on an insulin pump, they're good candidates since the insulin pumps now often are pairing with a sensor glucose and using artificial intelligence to adjust insulin basal rates. If they have frequent hypoglycemia or hypoglycemia unawareness, a high degree of glycemic variability, or they're not achieving their glucose targets, they may be good candidates for CGM. And the standards of care in diabetes do recommend that individuals with diabetes should be offered CGM if they're on multiple injections, 3 injections a day, for example. If they are adults on basal insulin that's not in target, if they're a youth with type 1 or 2 on multiple doses of insulin or an insulin pump, or pregnant females with diabetes as an adjunct to pre and postprandial blood glucose monitoring. The standards of care also recommend that individuals seeking CGM or their caregivers should be able to use the devices safely, and the choice of the device should be made based on their patient's circumstances and desires and needs, so individualized care there. They also recommend training. So no device used in diabetes management works optimally without education and training and follow-up. So there are some nice little graphics here on which to kind of think about how to help someone decide on a device. ICC framework, I stands for identify the right technology for the right person at the right time. So you might want to, if you're talking about sensors, you might want to find out, is this person going to go on a pump? Which pump they're thinking of, because there are sensors that connect to that pump. You may want to start them on the one that connects to that pump. If they're not, definitely you're going to want to see if they're Medicare, they're going to need one that has the reader. If they're not on Medicare, they want to make sure that they have the app on their phone. So you might even be asking them to kind of look that up ahead of time before making a decision. And then configure, really think about what their highs and low alarms should be so they don't have alarm fatigue and take the thing off, which happens all the time. So you want to kind of discuss with them what their high alarm and low alarm should be. And that really they need your help with that a lot of times. And then collaborate means have them come back and talk about their readings and strategies for improvement. And then this is just kind of a graphic that kind of gives you some, I think Dexcom came up with this one in collaboration with Certified Diabetes Educator. And it's, kind of a framework for downloading the data and then really looking for the hypoglycemia first and assessing the safety of that. Looking at best days where their time in range occurs and asking questions about what was going on this day when this was your best day. What are some things that you did or what happened if they can remember anyway? And then look at areas to improve and come up with an action plan during the visit. So nice little frameworks there. And of course, we want to think about glucose targets for our patients. They really need to know what their targets are. And, I'm sure you guys realize, a lot of you that see people with diabetes, they often really don't have any idea of what safe numbers. I've seen people with type 1 that think their sugar is always supposed to be under 100. I've seen, type 2s that think I only feel good when I'm above 200. So, they may have some unrealistic targets, in other words. So it's really nice to kind of sit together, be on the same page with, what is your target area? And of course, depending on their age, you see the targets may go up. So this is like, ambulatory glucose profile targets. And this was derived from a consensus report that, time in range 7180, greater than 70% is a good target, less than 25% of the time over 180, and less than 5% over 250, less than 4% below 70, less than 55, less than 54, less than 1%. But if they're older, their targets might be a little bit different. So for older individuals with comorbidities, reduced cognitive or functional status, or hypoglycemia unawareness, you may be looking for more like 50% in target and less than 1% low. So of course, their targets they would have maybe higher numbers. I love looking at the reports too, and I love the fact that they put all of the data on average on a 24-hour scale. So it's really simple for the practitioner and the patient to sit there and look together and really just ask some questions. What do you see here? And what's going on? Why do you tend to go to bed at night? So that can really open up conversation about maybe fear of lows, that are residual over time, and they just like to go to bed really high because they're so afraid of lows. And just maybe really kind of talking about some strategies to bring that down. And then you can see below, it has all the different days, so you can kind of see the patterns, and really come to some conclusions with the patient during a visit. CMS. Now I just get a feeling that insurance is always a moving target, so I'm just going to say what I think is the facts right now. For Medicare to cover CGM, the patient must have a diagnosis of diabetes, either 1 or 2, and be on 3 injections of insulin a day, and require frequent adjustment of the regimen. The order must include a durable CGM receiver, and is covered under Medicare Part B as a medical durable supply. So if anybody knows different, just chime right in there afterwards. And also wonderful news is Ohio Medicaid is taking out some of those requirements of prior authorization and months of 4 sticks a day in order to get CGM. So now it's covered if a person has type 1 or type 2 and 1 or more of the following conditions: frequent insulin dosing on an insulin pump, an A1C outside of target, fasting or postprandial hyperglycemia, unexplained hypos, despite appropriate changes in therapy, hypoglycemia unawareness, microvascular complications, or a condition that makes hypoglycemia management difficult, recurrent DKA, no PA required, and it's a pharmacy benefit. And then there's some references and product websites.
Okay, thank you, Karen. Great overview and some really valuable information. So before we move to our cases, are there any questions for Karen before we get to the cases?
I was wondering how best to document the data from the continual glucose monitor in the clinical notes, in terms of, traditionally, say, for example, for somebody who's just tracking via finger stick, we document a fasting, typically postprandials, but say, for example, for a continual glucose monitor, would you want just basically the trend, like, high, low, average, if possible?
Well, I'll just tell you what I do, but I guess I definitely want the providers to chime in too. As a diabetes educator, if I have someone and we're looking at their, I look at the AGP, the ambulatory glucose profile, and we're kind of shooting for, with a lot of people, 70% time in range. So I might say their time in range is 53%. The goals for above 180 is often, less than 25%. So I will document that, and then any lows. Yeah, and that kind of helps you kind of put it in perspective anyway.
Wonderful. Thank you so much.
Anybody else has any input on that?
When I chart them, we utilize Epic now, and I just use the snipping tool to take pictures of the AGP and copy and paste those into the chart so the provider can actually see exactly what I'm looking at. If I don't have access to that, like if they're using a receiver, so I don't have access to see their current AGP, I'll usually document, I'll have them go into their receiver, if they're the Libre 2, and look at time spent in the target range, as well as their average glucose, which then I can utilize to calculate a GMI. And I'll include all of that for my prescribers.
Megan, do you cut and paste it into a office note, or where does it go?
Yep. Yeah,
okay.
Just directly into, I typically see patients over telemed, so I just copy and paste it into my telemed chart note.
And it looks like Dr. Dungan is something similar. Take a snapshot and dates and interpretation. Okay, pretty similar. Good suggestion. Thank you.
I just wanted to mention real quick too that one of the slides there, it recommends that if you're going to look at GMI, that you have at least 14 days of CGM data. And I think that that's really important to know, because sometimes you'll look at that GMI and you'll think, well, why is it so different from their A1C that they recently had? So really think about, whether they've got enough data to do a decent GMI or not.
All right, let's go back to Claire for a minute to wrap up.
Just a reminder, the post-clinic survey should be in your email. If you could take a moment to complete that, we would appreciate it, to provide feedback from this morning's talk. And then my usual case study, if you have not submitted both of your case studies, please let me know. If you need your link again, I will be reaching out soon with the schedule. And as always, if you need to contact us, please feel free to do so.
Okay, thanks everyone. We'll see you next week. Great discussion today. Bye-bye.